Bismillahirrahmanirrahim. My talk is about the impact of proton pump inhibitors on mycophenolate, actually mycophenolic acid pharmacokinetics in kidney transplantations. This study was not done in Egypt. This study is done in Kuwait in collaboration with Bani Suef University. And the clinical pharmacy department in our university was the one who is the leader for this study. Introduction. Since 195, mycophenolic acid is considered as a standard agent in the prevention of organ transplant rejections. Currently, two mycophenolate formulations are available in the market: mycophenolate mofetil and the enteric-coated mycophenolate sodium. Following the administration, both are rapidly hydrolyzed to mycophenolic acid. The success of the transplant process depends on the correct and continuous use of immune suppressants and other medications. These medications can cause some unwanted drug-drug interactions and may lead to an increase or decrease in the immunosuppressant's blood levels. Proton pump inhibitors are widely used to treat hyperacidity and other GI complications associated with the use of immune suppressants, especially steroids. PPIs interact with many medications because of its effect on the stomach pH and may alter the absorption of an immunosuppressant agent affecting the transplanted kidney. A cross-sectional non-randomized study was carried out in the outpatient department at Hamad Al Isa Organ Transplant Center in Kuwait. Patients were 21 years old and above, 6 months or more after transplantation, and with stable graft function, and all signed everything consent. The main immunosuppressant protocol at the local center, including prednisolone, tacrolimus, omeprazole 20 mg twice daily, and either MMF or enteric-coated mycophenolate sodium. The aim of our work is to compare the impact of concomitant use of omeprazole on mycophenolic acid exposure area under the curve 0 to 12 hours and C0, which is the concentration at the pre-dose test done in patients treated with MMF or enteric-coated mycophenolate sodium, besides to assess the attainment of mycophenolic acid area under the curve target level using both formulations. Participants were asked to come fasted overnight without taking their morning doses. Pre-dose mycophenolic acid sample were collected. Then the participants received their omeprazole dose 20 mg along with either MMF or enteric-coated mycophenolate sodium. 2 more blood samples were collected at time 1.5 hours and 3.5 hours post-dose. At the patient stay for maximum 4 hours during their outpatient visits after 6 months of transplantation, of course. Mycophenolic acid area under the curve was calculated using the limited sampling strategy based on the multilinear regression as per Musamba et al. 2013, who did the mycophenolic acid level for 12 hours, and they make an equation so to be able to calculate from only 2 samples how they can actually measure the mycophenolic acid level. The area under the curve was equal 16.5 plus 4.9 multiply the serum level at 1.5 hour plus 6.7 multiply 3.5 hour concentration level to predict the mycophenolic acid area under the curve. The results was more than 50% of the patients were males in both groups, and the majority received 1,500 milligrams and 1,080 milligrams per day from MMF or the enteric-coated mycophenolic acid respectively. There was no statistical significant difference in laboratory results from both groups, and this is the demographic table for both groups. The mycophenolic acid exposure was measured concentration for MMF and enteric-coated mycophenolate sodium group are shown in table 2. There was no statistically significant difference in mycophenolic acid area under the curve and C0 between MMF and enteric-coated mycophenolate sodium. The P level was 0.16 and 0.0225 respectively. However, the MMF group has high levels of concentration in 1.5 hours, and enteric-coated mycophenolate sodium has higher concentration in 3.5 hours. This is the table 2 showing no difference between two groups, but the Cmax was high in MMF group and C3.5 was higher in the enteric-coated mycophenolate sodium. The percentage of patients whose area under the curve estimated were below, within, or above the target ranges with MMF and enteric-coated mycophenolate sodium are reported in table 3. Target mycophenolic acid area under the curve of 30 to 60 milligram per hour per liter was achieved in 46 and 36% of MMF and enteric-coated mycophenolate sodium respectively. High proportion of patients had their mycophenolic acid area under the curve above 60 milligram, with 54 and 62 in MMF and enteric-coated groups respectively, with p-value 0.15. These are table 3 showing the 2% of the patient was under the therapeutic level, and 36% was in the therapeutic range, and 62% were above the therapeutic range. The number and percentages of the patient who had mycophenolic acid area under the curve above 60 are presented in figure 1. More than 80% of the patient who received 1000 milligram MMF has area under the curve above 60 milligram per hour per liter, compared to 56.25 with the equivalent enteric-coated mycophenolate sodium. 18 patients has 75% who received enteric-coated mycophenolate sodium 1080 milligram had area under the curve above the target range, compared to 10 patients 43.48 on 1500 milligram. In the 2000 milligram MMF and 1440 milligram enteric-coated mycophenolate sodium group, the percentages were 55 and 40% respectively. This is the figure showing the data collected from our patients. There is a poor negative correlation found by the Z0 and the predicted area under the curve in the MMF group, with no statistical significance. Discussion, Miura et al. 2008 observed that both mycophenolic acid area under the curve and mycophenolic acid plasma concentration significantly decreased with the use of the lansoprazole in renal transplant patients. On the other hand, the use of pantoprazole didn't alter the pharmacokinetics of mycophenolic acid in a study done by Ruprochat et al. In 2009. As a PPI, omeprazole increases the gastric pH that might affect the absorption process of co-administered oral medication, in particular those who are formulated to be absorbed in low pH like MMF. On the other hand, the effect of the PPI were excreted to be diminished with the intestine, were expected to be diminished with the intestine absorbed drugs like enteric-coated mycophenolate sodium. In a Chinese study done by Zhu et al. In 2014 showed that omeprazole was reported to significantly decrease mycophenolic acid area under the curve by above 35%. With MMF compared to enteric-coated mycophenolate sodium treated patient. while in Fernandez, Rivera et al. In 2014, both MMF group and enteric-coated mycophenolate sodium patient experienced high exposure to mycophenolic acid with the use of omeprazole when compared to non-omeprazole patients. In the current study, the enteric-coated mycophenolate sodium group had a non-significant higher levels than mycophenolic acid area under the curve when compared to the MMF group. Our results were going with David Nito et al. In 2012, who mentioned that the reduction of the omeprazole on mycophenolic acid pharmacokinetics can be observed only in the first week post-transplantation, but it's clinically irrelevant after this week. The time after the transplantation could be used as an explanation for the discrepancies observed between the results and the previous results. For example, omeprazole significantly affect mycophenolic acid pharmacokinetics in the Zhu et al. Study, as I said before. That use investigated mycophenolic acid sample for only new transplant patient, not after 6 months follow-up like our study and the Fernandez Rivera et al. Another crucial factor that might explain the difference in the results is related to the omeprazole brand. This is by Shimin et al. In 2006, which concluded that the acid suppression of some brands of the generic omeprazole was different from the original product, and this variation may have the impact on the clinical outcomes. Our study was the only study done on omeprazole that make unification for all the patient who is receiving omeprazole on only one brand, which is Minisic 20 milligrams before each dose. As expected, the concentration in 1.5 hours was higher in MMF group, and 3.5 hours was higher in the enteric-coated mycophenolate sodium group. This can be explained according to the site absorption of each drug. Mycophenolic acid is absorbed mainly from the stomach. It reaches maximum concentration in the blood after about 1 hour, while enteric-coated mycophenolate sodium is absorbed from the intestine and reaches its maximum concentration in the blood after 1.5 to 2.5 hours. Many studies highlighted the strong correlation between mycophenolic acid levels and its pharmacokinetics efficacy and toxicity, especially with the strong after individual variability noted in the pharmacokinetic parameters with this patient who used the same dose. Therefore, mycophenolic acid monitoring is required to optimize its exposure and dosing. A consensus guideline recommended to monitor mycophenolic acid area under the curve and the target range to be within 30 to 60 milligram per hour per liter. In the present study, more than 50% in our group high mycophenolic acid level of 60 milligram per hour per liter or more, exceeding the target range. Higher concentration of mycophenolic acid doesn't increase the rate of acute rejection and may lead to increased risk of infection, anemia, and bone marrow suppression. This result necessitates the revision of the transplant center protocol that use MMF and enteric-coated mycophenolic acid in fixed daily doses and give the possibility to apply the mycophenolic acid therapeutic drug monitoring and treatment personalization in the near future. The time-dependent characteristics of the area under curve of mycophenolic acid is another reason to evaluate the mycophenolic acid exposure after 6 months of transplantation. The center protocol should be reviewed because the mean area under the curve of mycophenolic acid in the last post-transplantation 3 to 6 month is almost 40% higher for the same dose than in the early post-transplant period. So we have to revise the level of the mycophenolic acid every 3 months in the first year of post-transplantation period. Although the pre-dose concentration could be used to evaluate the drug exposure, its application is weak due to poor correlation with the main area under the curve of mycophenolic acid, which is considered a better predictor of mycophenolic acid clinical outcomes. 23 patients in both groups had C0 above 2.75 milligram per liter, 17 in the MMF group and 6 in the enteric-coated mycophenolate sodium group. This requires further attention in the future. Using omeprazole with mycophenolic acid formulations, MMF and enteric-coated mycophenolic sodium didn't result in different exposure and pre-dose concentration in the late post-transplant period. This suggests there is no need to change between the two formulations, no need to shift from this formulation to this formulation when used with omeprazole. However, the analysis of mycophenolic acid exposure indicated unexpectedly high exposures with the use of both formulation. The authors recommended the use of individualized mycophenolic acid dosing instead of fixing daily dose. And thank you. The next slide was